You are standing in your kitchen when your right eye goes dark. Not blurry, dark, like a curtain dropped over exactly half of what you were looking at. You blink twice. You press a finger against the eye. 30 seconds later, the curtain lifts and everything looks normal. You stand there for a moment, decide it was probably nothing, and pour your coffee. What just happened in your body was not probably nothing. It was a recognized clinical emergency with a name, a mechanism, and a 72-hour window during which a great deal can still be done. The problem is not that medicine cannot help you at that moment. The problem is what happens when you walk into the emergency room and say, "My eye went funny for a bit." The part nobody tells you clearly enough is this. The medical system is not designed to catch a transient ischemic attack in a patient who arrives neurologically intact. It is designed to identify an active stroke in progress, stabilize it, and move to the next case. Those are two completely different clinical problems, and the tools used for one are largely useless for the other. When a TIA has already resolved by the time you walk through the door, your exam is normal. Your reflexes are symmetric. Your speech is clear. Your grip is equal on both sides. To the clinician running a 12-minute assessment, you look like someone who came in unnecessarily. Not because they are wrong about what they see, because what they see is the expected appearance of a resolved transient event, and nothing in the 10-minute window flags it as the warning it actually is. Think of the system as a clock running on a 10-minute cycle and your body running on a 72-hour one. Those two clocks do not overlap in any useful way unless you force them to. The emergency department clock resets with every case. Your vascular clock started the moment your eye went dark in the kitchen, and it will keep running whether or not the discharge note says no acute findings. That mismatch is not a design flaw. It is a design choice built around the most common presentations, and a resolved TIA in a neurologically intact patient is not the most common presentation the system is optimized for. It is the one that slips through. The imaging gap is worth understanding precisely because it surprises people most. A CT scan without contrast is the standard first-line tool in most emergency settings. It is fast, widely available, and reliably rules out hemorrhage. What it does not reliably show is early ischemic injury, particularly in the posterior circulation, the brainstem and cerebellum, and in small lacunar events deep in brain tissue. For those, you need an MRI with diffusion-weighted imaging, a different and more time-intensive study that many emergency departments do not order as a default. A normal CT after a TIA is not reassurance. It is expected. In clinical practice, a normal non-contrast CT following a transient neurological event tells you one thing only: there is no active bleed. It does not tell you whether ischemic injury is present, whether a plaque is unstable, or whether the event will repeat. Doctors call a missed early infarct on CT a false negative, not a misread. The scan did exactly what it was designed to do. The problem is that the right tool was never requested. The rhythm problem works the same way. A 10-second electrocardiogram captures one brief snapshot of cardiac electrical activity. Atrial fibrillation, the heart rhythm disorder responsible for a significant share of cardioembolic strokes, is intermittent in many patients. It appears for seconds or minutes, generates a clot, then disappears. A 10-second window catches it only if it happens to be firing at that exact moment. Not X. A normal 10-second ECG does not rule out atrial fibrillation. Standard stroke guidelines recommend 24-hour Holter monitoring specifically because of this gap. But a Holter is an outpatient test, typically arranged at follow-up, which means days pass between the TIA and the recording. If the follow-up appointment is never made, the recording never happens. Then there is the demographic pattern, and this one is documented with enough consistency that it is no longer a matter of debate. Women are more likely than men to be discharged after a TIA without a complete workup. Patients under 50 are more likely to have their symptoms attributed to migraine, anxiety, or functional disorder rather than vascular cause. Patients who arrive without a classic deficit, no facial droop, no arm drift, no dense hemiplegia, are more likely to be triaged at lower acuity and seen later, after the transient window has already closed. Studies show these patterns are not explained by differences in actual stroke risk. They are explained by differences in how symptoms are described, how they are received, and which clinical features activate protocol responses. The assumption is that a resolved symptom means a resolved risk. In reality, a resolved symptom in the context of a TIA means the warning has been delivered and the clock has started. Those are not the same situation, and they do not call for the same response. The 72 hours following a transient ischemic attack represent the period of highest stroke risk, not the period of reassurance. A system that closes a case inside that window without the 3 evaluations most likely to identify a preventable cause has processed the available information correctly and reached the wrong conclusion, because the available information was incomplete. What changes the outcome is not a different system. It is a different patient walking into the same system, carrying different words. Picture 2 versions of the same Tuesday morning, same emergency department, same attending physician, same waiting room with the same flickering overhead light. In the first version, you sit down across from the doctor and say you had some dizziness earlier. Your arm felt a bit off, and your words came out strange for a minute, but then it passed and you feel fine now. The doctor documents dizziness, resolved paresthesia, no focal deficit on exam. CT is ordered, comes back normal, and you are discharged with instructions to follow up with your primary care physician within 2 weeks. In the second version, you sit down and say something different. The room does not change. The doctor does not change. What changes is what the system hears and what it is required to do next. Clinical language is not jargon for its own sake. It is a coding system. When a clinician hears a specific term, a specific pathway activates, not because of bias toward educated patients, but because those terms carry precise diagnostic weight that a lay description does not transmit. When you say your arm felt a bit off, the clinician hears a non-specific complaint that could originate from a pinched nerve, a panic attack, poor sleep, or a dozen other benign causes. When you say you experienced unilateral paresthesia lasting approximately 4 minutes with spontaneous resolution, the clinician hears a lateralized, time-limited neurological event with a defined onset and offset, not a vague complaint. A TIA descriptor. One of those generates a note, the other triggers a protocol. There are 3 symptom descriptions that carry the most clinical weight in the stroke and TIA context, and each has a name you can learn, use accurately, and deploy without any medical background. The first is amaurosis fugax. In plain language, this is temporary blindness or severe visual dimming in one eye only. The curtain-dropping sensation, the gray smear across the visual field, lasting seconds to a few minutes before clearing on its own. When you describe this as temporary vision loss in one eye, you may receive a note that reads visual disturbance, etiology unclear. When you say I experienced an episode of amaurosis fugax approximately 2 hours ago, the clinician hears a recognized TIA equivalent with a known vascular mechanism, an embolus to the ophthalmic artery, a direct branch of the internal carotid that also feeds the brain. Neurologists treat that phrase like a fire alarm, not a symptom to monitor, a reason to act within hours. The second term is unilateral paresthesia, numbness, tingling, pins and needles, a feeling of rubber or cotton affecting one side of the body only, one arm, one hand, one leg, or one entire side including the face, appearing without any positional cause and resolving without any change in posture. Not both hands evenly, not a foot that fell asleep after sitting cross-legged. One side, spontaneous onset, clearing on its own. Those three features, laterality, spontaneous onset, and self-resolution, are what separate a vascular event from a peripheral nerve complaint. And when you include all three in your description, you are giving the clinician the complete picture rather than a fragment of it. A fragment gets a note. A complete picture gets an order. The third is transient dysarthria, a sudden breakdown in the mechanical production of speech, words coming out slurred, fragmented, or physically stuck, while you understood everything being said to you and knew exactly what you wanted to answer. Not forgetting a word, not losing your train of thought. The motor output of speech collapsing briefly and then returning. When you say my speech came out wrong for a minute, you may be documenting stress. When you say I experienced transient dysarthria with complete spontaneous resolution, you are documenting a recognized sign of reduced perfusion to the speech production areas of the dominant hemisphere. Not X. Those are not the same clinical entry, and they do not produce the same response. Knowing the terms is the first layer. Deploying them inside the conversation is the second. The 72-hour window is not just a fact you carry internally. It is a sentence you say out loud, and the sentence is this: I understand my symptoms have resolved, but I am presenting within the 72-hour high-risk window following a suspected TIA, and I would like to be evaluated accordingly. That sentence does three things at once. It demonstrates clinical awareness, which shifts the register of the interaction. It explicitly names the time window that stroke guidelines use to define urgency. And it reframes your resolved symptom not as reassurance, but as the expected presentation of a transient ischemic attack, which is, by definition, transient. A symptom that resolved is not a symptom that was imaginary. It is a symptom that behaved exactly as TIA symptoms behave. After describing your symptoms in clinical language and invoking the window, the next step is to ask for the three evaluations by name. The request is not a demand. It is a direct question. I would like to ask whether a carotid duplex ultrasound, an HbA1c blood test, and a 24-hour Holter ECG would be appropriate in my case. Each targets a different mechanism. The carotid duplex looks at plaque burden and flow restriction in the neck arteries. The HbA1c reflects average blood sugar across the past 3 months and catches pre-diabetic endothelial damage that a single fasting glucose will miss entirely. The Holter catches intermittent atrial fibrillation that a 10-second ECG cannot see. Naming all three signals that you understand what you are asking for and why, which makes it significantly harder to substitute a partial workup for a complete one without that substitution becoming a visible, documented choice. The final request in this sequence is the one most people never think to make. You can ask, by name, for a stroke neurologist rather than accepting evaluation by a general emergency physician alone. The phrasing that keeps the exchange collaborative rather than adversarial is, would it be possible to have a stroke neurology consult given the nature of my symptoms? In a certified stroke center, this is a standard pathway. In a general emergency department, it may require the request to be stated explicitly. Not because the emergency physician is less capable as a clinician, because a neurologist evaluating a post-TIA patient applies a different and more specific diagnostic lens to this particular problem, and that lens is what the situation calls for. The written symptom log is the most underestimated tool you can bring into a clinical encounter, and almost nobody brings one. Not because it requires medical training to produce, but because nobody explains what it actually does to the dynamic of the room. When you hand a clinician a written account of your symptoms before they have finished their opening question, you have done something structurally significant. You have created a document. The moment a clinician reads it, its contents become part of the encounter, and omitting a workup that directly addresses what is written becomes a documented decision rather than an invisible one. That is not a confrontational move, it is a structural one, and the asymmetry it creates works entirely in your favor. The log does not need to be long, it needs to be specific. For each episode, record the date and time it began, the duration in minutes, the exact symptoms using both plain language and the clinical terms from the previous section, which side of the body was affected, whether the symptom resolved completely or partially, and what you were doing when it started. If you experienced amaurosis fugax, right eye, complete visual loss, curtain down sensation, duration approximately 3 minutes, spontaneous full resolution, standing in kitchen, 7 in the morning. If you experienced unilateral paresthesia, left arm and hand only, pins and needles with rubbery sensation, no positional cause, resolved without movement in 4 minutes. Precision here is not pedantry. Each specific detail maps onto a clinical decision tree. Vague entries generate vague responses. Specific entries generate specific orders. The log also solves a problem clinicians almost never name for patients. Memory degrades under stress. A person sitting in a fluorescent-lit room describing a frightening neurological event from 3 hours ago is not recalling it with full accuracy, and they know it, which adds another layer of interference to the account. A written record made within minutes of the event removes that variable entirely. Hospital records show a pattern where detailed written symptom accounts result in more complete initial workups, not because clinicians are rewarding effort, but because the information required to make a decision is present on the page rather than reconstructed under pressure in real time. Where you go matters as much as what you say when you arrive. Think of the 10-minute emergency department clock again, the one that runs on a different cycle than your 72-hour vascular window. In a general community emergency department, that clock governs everything. Which tests are default, which consultations are available, which protocols exist for a neurologically intact patient describing resolved symptoms. In a certified stroke center, a parallel infrastructure exists specifically for this situation. 24-hour neuroimaging, stroke neurology coverage, a defined TIA evaluation protocol that does not need to be assembled from scratch when you walk in. Asking for a carotid duplex and a Holter ECG in a certified stroke center is a routine request that fits an existing pathway. In a facility without that designation, the same request may require a chain of escalations that consumes the window you are trying to use. This does not mean you bypass the nearest hospital if symptoms are active right now. Time to evaluation outweighs facility type in an acute event. But if your symptoms have resolved and you are deciding where to present for workup, and a certified stroke center is within reasonable reach, that choice changes what happens next in ways that matter. You can identify certified stroke centers through your National Stroke Association website or by calling ahead and asking directly. Is this facility a certified stroke center with a TIA evaluation protocol? Any reception desk can answer that question. The right to a second opinion does not require confrontation, and it should not be framed as one. The sentence that exercises the right while keeping the interaction constructive is, "Before I am discharged, I would like to request a second evaluation of my case." Not, "I do not trust your judgment." Not, "I want to speak to someone else." A second evaluation, requested before discharge, while you are still a current patient, is a standard right in virtually every healthcare system. It is also significantly easier to exercise before you leave than after you have been handed a discharge summary. Once you walk out, the clinical interaction is closed. The leverage that exists while you are a current patient does not follow you to the parking lot. If you are dismissed after using clinical language, invoking the window, requesting the 3 tests by name, asking for neurology, and requesting a second evaluation, documentation becomes your next tool. Before you leave, write down the name of the treating clinician, the time you were seen, the specific evaluations you requested and were not offered, and any reason given for not ordering them. Keep the discharge summary. Note the time of discharge. This is not preparation for a legal action. It is the creation of a record that allows the next clinician who sees you to understand exactly what workup was and was not completed, so the gap in the prior evaluation is visible rather than invisible, and so you are not starting from zero in the middle of the window that is still running. The assumption when a patient returns within 72 hours after a prior emergency visit is that they are anxious or presenting unnecessarily. In reality, a patient returning within the high-risk window after an incomplete workup is precisely the patient whose prior record should be reviewed before any other conclusion is reached. Not X. Your documentation from the first visit is what makes that review possible rather than hypothetical. In the first 24 hours following a suspected TIA, the priorities are these. Do not be alone if you can avoid it. Do not drive. And measure your blood pressure if you have access to a cuff. If the systolic reading is at or above 180, or the diastolic is at or above 110, that is a hypertensive crisis, and calling emergency services immediately is what standard guidelines recommend, independent of your neurological symptoms. Write down every symptom that appears or recurs, however briefly, with time and duration. If a new neurological event begins, any sudden one-sided weakness, speech failure, facial asymmetry, or loss of vision, treat that as an active emergency and go directly to the nearest stroke-capable facility. At the follow-up appointment that should occur within 48 to 72 hours, there are 3 specific conversations to have. Ask whether a carotid duplex ultrasound has been ordered. A narrowing of more than roughly 70% in the carotid artery is hemodynamically significant, meaning blood flow is impaired enough that the clinical question shifts from whether a stroke could happen to when it will happen if nothing changes. Ask whether your HbA1c has been checked. A result between 5.7 and 6.4% indicates pre-diabetes, a range where blood sugar has been elevated long enough to damage the endothelial lining of your vessels without carrying a formal diagnosis. Ask whether a 24-hour Holter ECG has been arranged. A normal 10-second ECG does not rule out intermittent atrial fibrillation. In clinical practice, those are not interchangeable results, and your clinician should be able to explain the difference when you ask. The phrase, "I was told I am fine," is one of the most consequential pieces of incomplete reassurance in medicine. Fine on a non-contrast CT, a 10-second ECG, and a 12-minute exam is not the same as fine on a carotid duplex, an HbA1c, and a 24-hour Holter. Not X. One is a partial picture taken with the wrong instruments inside a 10-minute clock. The other is a complete one. You are entitled to know which one you received. Write down what happened, when it happened, and which side of your body it affected. Bring that written account to your next medical encounter. Ask for the carotid duplex ultrasound, the HbA1c, and the 24-hour Holter ECG by name. The window is 72 hours, and it started the moment the symptom appeared.